morning, everybody. Thank you for joining us this morning. Today, we are talking about more or less every single woman that I know, their struggles, no matter how old they are, if they're in their teens or 30s or 40s, or even actually entering menopause. We all suffer, period pains, me included. Today, we're talking about, I have to make sure I say this right, polycystic ovarian syndrome and endometriosis. I hope I said that right, Dr. Anu. So joining us this morning is Dr. Anupriya. Dr. Anupriya is award-winning senior obstetrician and gynecologist with over 25 years of experience. Dr. Anupriya, before we start with your slides, for the people who don't know you, can you please tell us a little bit about yourself and what you specialize in?
Thank you very much, Susan. So I am a mother of two, and I'm also an obstetrician and gynecologist. I have been doing this since, almost 25 years. Next year will be 25 years. I deliver babies, of course, but bulk of my practice is now dealing with gynecological issues as well as fertility issues in women. And I am currently practicing at Mount E Orchard. I was at NUH for the longest time, for about 19 years. I was there till last year when I decided to switch over to private practice. So here I am, and I am passionate about women's issues. I feel that women really suffer a lot, and in today's day and age, there should be no women who has to do that. There is treatment for almost every single gynecological problem, and there's no reason why, especially in a place like Singapore, that women have to suffer in silence. So webinars such as this are very important in spreading awareness of various types of treatments that are available, what symptoms to watch out for, as also lifestyle measures that can, without medication, help us deal with these issues that many, many, many women suffer.
Exactly. And we're so happy to have you this morning. And, I just wanted to say to everybody, please, if you have important questions or if you have anonymous questions, you can directly shoot it in the chat to me, and then I'll ask it to Dr. Anu. So Dr. Anu, thank you so much. And let's start with your slides.
Okay, so today we will be talking about two important issues. We'll be talking about period problems, because those are the bane of any woman's existence. But we will be specifically talking about two things today, which are very, very common: PCO, or polycystic ovarian syndrome, and endometriosis. We'll start off with PCO, and then we'll go on to endometriosis. PCO is literally a lifelong sentence. In my talk today, we'll be talking about what is polycystic ovarian syndrome, or PCOS, the genetic basis of PCO, how do we diagnose it, the journey of PCO through the lifespan, starting from intrauterine, when we were a little baby in the mother's womb, to moving on to the adolescent presentation, and then how it presents in adult life. And then we'll be talking about treatment options, both lifestyle as well as hormonal and non-hormonal treatments that women can use today to deal with this problem. And then we'll talk a little bit also about chronic disease monitoring, which is very important in women who have PCO. So let's start. What's PCO? PCO basically means polycystic ovaries. Now, this is a pictorial depiction of a normal ovary. In the normal ovary, there are tiny little eggs. These eggs grow in response to the brain hormones. This makes the eggs grow and develop. These eggs get released. in the middle of the cycle, aiming for a pregnancy. If no pregnancy happens, then periods come. So this cyclical growth of eggs and no pregnancy will result in periods to happen. Now, if a woman's hormones are balanced, this cycle is regular and she has regular periods or regular menstruation. On the other hand is the PCO ovary. PCO, what does it mean? Polycystic ovary. So poly means many, cis means fluid-filled spaces. So PCO ovary means an ovary with many fluid-filled spaces. These are cis, but compared to big ovarian cyst, that is a single fluid-filled structure in the ovary, often 3, 4, 5 centimeters or larger. The PCO ovary has many, so hence the word poly, so many small cystic spaces in the ovary. And this is because of a hormonal imbalance. This hormonal imbalance results in the egg not growing well. And when it doesn't grow well, it doesn't get released. When it doesn't get released, these eggs, they remain in the ovaries in the form of small cysts. Hence, the PCO ovary has many small cystic areas. And later I will show you some ultrasound pictures will help you visualize and see what a PCO ovary looks like. So it's a very common endocrine disorder. It affects about 10% of all women. And it can have several possible presentations. It could be reproductive presentations, which means irregular menses or fertility issues. There could be aesthetic problems like acne, hirsutism, obesity, hair fall. It could be metabolic alterations like diabetes, hypertension, high blood pressure, high cholesterol. It could lead to serious long-term health issues like preeclampsia and cancer of the uterus. Infertility and miscarriages are an important part of PCO presentation. And then pregnancy complications can also happen. Premature labor, diabetes, and a very small or very large baby. And generally speaking, while all women may not have all of these symptoms, but symptoms will generally worsen with increasing weight. And I say generally because there is a subset of women who have skinny PCOS, who are the skinny PCOS. So for them, PCOS is not related to their weight. So question is, why does PCO happen? The genesis of PCO is in either genes. So some of us have the genes that make us develop this hormonal imbalance, and obesity, or it's just obesity, but or obesity will enhance the effect of the genes. But basically what this does is that these genes do not let the insulin hormone work very well. So insulin is a hormone that helps us digest carbohydrates. And if it doesn't work very well, then the carbohydrate levels rise. As the carbohydrate levels rise, or if we are consuming very high carbohydrate diet, both these things, insulin resistance coupled with a high carbohydrate diet, can result in hyperinsulinemia, which means high insulin levels. High insulin levels through a very complex mechanism results in high male hormone levels, and this high male hormone level will result in acne and hirsutism, which are hallmarks of this condition. This hormonal imbalance will again result in irregular periods and fertility issues. Metabolic changes because of the high insulin levels and the high male hormone in a woman will aggravate the obesity and result in metabolic problems like diabetes and high blood pressure. And if none of this is rectified, it just persists on for years and years, then there is an increased risk of certain cancers, especially cancer of the uterus or the womb. Now, PCO seems to have a polygenic inheritance, which means there's no one gene that makes a woman have PCO. There are several genes and we don't know why. That's why there is no genetic test for PCO. But all these genes, the effect of these genes is exacerbated by environmental factors, especially obesity. Because of the genetic basis of PCO, we are able to see a familial clustering. So a lot of women with PCO will have sisters or mothers also affected by the same thing. but it is very, very dependent on the lifestyle, and body weight and BMI can change the way PCO presents in a woman. Now, I find this very, very interesting, the intrauterine origin of PCO, which means PCO starts developing from fetal life. So if a PCO mother who has not very well controlled PCO, she conceives, oftentimes with some treatment, that can result in insulin resistance in the fetus. And this insulin resistance basically means that this baby is not able to get enough food during the fetal life. Oftentimes, these babies are born small for gestational age, or IUGR, intrauterine growth retarded. So these babies are small babies because even though the mother is big sized, because of the hormonal imbalances and the insulin metabolism issues, she is not able to nourish her baby very well. So babies are having this problem of undernutrition during the fetal life, and that programs them. So when this baby is born, the memory of this undernutrition during the fetal life persists, and this results in a thrifty metabolism. So this baby's body is programmed to keep saving for a rainy day. Now, when this baby is now exposed to nutritional surplus, and this baby comes out small, the mother overfeeds the baby. So, oh, I need my baby to grow big, but doesn't realize that this baby is programmed for a thrifty or a starvation metabolism, which means whatever we give you, the body stores that because it keeps thinking, oh goodness, I don't know whether I will get enough food for my needs or not. So this results in rapid weight gain in later life. And that is evidenced by child obesity. And if this goes uncorrected, then it will result in premature puberty. And again, if that is not corrected, then it can lead to the development of chronic diseases like PCO, metabolic syndrome, type 2 diabetes, and high blood pressure. Of course, at various parts of the body, of the person's life, there are opportunities for multidisciplinary therapeutic interventions, specifically lifestyle modifications, as well as some medications to correct these PCO symptoms and bring it back to normal. Okay, so how do we diagnose this disease? There are 2 out of 3 criteria that are needed for the diagnosis, and these being irregular periods, high male hormone in the body, and multiple ovarian cysts on ultrasound scan. So this is what the ultrasound picture of a PCO ovary looks like. There are multiple small eggs. We call it a string of pearls appearance. So this looks like a string of pearls on the periphery of the ovary. So this is what the ultrasound looks like. High male hormone could be clinical in the form of acne, which persists on beyond the teenage years, and hirsutism, which is quite obvious in certain ethnic groups, especially, otherwise by blood tests. And irregular, infrequent periods, which are usually more than 35 days apart. Now, not all women will have all of these, but as long as 2 out of these 3 criteria are met, the woman is diagnosed as having PCO. Now, what about the adolescent? If we scan the ovary of a teenage girl, the ovary will pretty much look like what I showed you just now. So PCO is basically a form of exaggerated puberty. Girls in PCO in puberty will have higher male hormone level. They have high number of eggs in the ovary. And hence, in the young girl, there is a danger of overdiagnosis. So there are different criteria of ovarian volume of ultrasound scan for labeling a ovary as PCO in the young girl. But this increased risk of metabolic syndrome is definitely there in adolescents with PCO compared to healthy adolescents. what we usually do, that if there is a girl who has irregular periods, we have to reevaluate it at least 8 years post the start of the period. For me, I usually will reevaluate it around the age of 20, 21 years. Because by then, there will be a certain subset who, if they are able to lose weight, their cycles will generally normalize. And we should not label them as PCO. Also, because if we label these girls as PCO, there's a lot of implications on insurance coverage later on in life. And that is something parents need to understand. Now, there is a big ethnic variation. Most Caucasians generally have a relatively mild phenotype. There is a higher BMI in Caucasian women. Indian, Middle Eastern, Hispanic, and Mediterranean women have more hirsutism. Southeast Asians tend to have more central fat, diabetes, and metabolic risks. Chinese women will have a lower BMI and much, much milder hirsutism. And in Africans, there will be higher BMI and metabolic features. There are specific long-term health concerns. We know that cardiovascular disease, heart attack, and stroke are 2 to 3 times higher in PCO women. And some of these things can happen at earlier ages, not in their 50s and 60s, maybe in their 30s and 40s. So PCO women should be monitoring for weight and cardiovascular risk every 6 months. Gestational diabetes, impaired glucose tolerance, and type 2 diabetes, these are also common, more common in Asians, so 5-fold more than other women in Asians, 4-fold in the Americas, 3-fold in Europe. And this is independent of obesity. So you could be slim, but if you have PCO, you will have these metabolic problems. So tests should be done at baseline and then 1 to 3 yearly, especially in those who have family history of diabetes or are of high BMI. Some women have obstructive sleep apnea, so they snore, and that itself is known to result in a variety of health problems. And then endometrial cancer, which is 2 to 6-fold higher in women with PCO. And in the specific thing about this in PCO women is that endometrial cancer in PCO girls will often present even before menopause, sometimes even in their 20s. The pregnancy of a PCO woman is higher risk, and there is an increased risk of miscarriage in the first trimester or in the second trimester. And in the third trimester, some women may have premature labor, gestational diabetes, as well as high blood pressure. And there are treatments for each one of these, which can be instituted now. So how do we diagnose? Mostly, if you go and see a doctor with irregular periods or other concerns that increase the risk of you having PCO, there will be certain blood work that needs to be done. It's a set of hormones that help us see whether your hormones are imbalanced and basically rule out other causes of hormonal imbalance. A pelvic ultrasound scan is done in most women who are sexually active. It should be done transvaginally because that's when you are able to see the ovaries well. Transabdominal scans are not so good. Other tests need to be done for metabolic parameters like sugar tests, lipid panel, etc. Now, what about treatment? The treatment essentially depends on the symptoms. If she has irregular periods, then the treatment is different types of hormones. It could be progestogens, which would all these will have different types of side effects. There are various doses that can be used. The advantage of using this one particular set of hormones, which is progestogens, is that it protects the endometrium from developing endometrial cancer. And this can be used for long periods of time. Can be used cyclically every month or every other month to give rise to regular periods. For women who need contraception, the oral contraceptive pill is a good option. Again, it's used cyclically, and this contraceptive not only protects the endometrium, but also helps with hirsutism and acne. The contraceptive patch can be used for women who don't like to take the pill orally or who are quite forgetful. So once a week, they change a patch. Again, it's a good contraceptive and can help with hair and pimple issues. Some women, they do not like to take medication, or who are not very good at taking medications daily, so they will forget. And in them, especially if we need contraception and endometrial protection, then using the Mirena intrauterine device is a good option. It does have the side effect of spotting for a few months, but the advantage is that it is inserted once every 5 years. What about women who present with acne and hirsutism? Various types of anti-androgen, anti-male hormone medications are used, but these will have to be used for prolonged periods of time. However, laser hair removal is now widely available and cost-effective and should be used to deal with hirsutism problems. What about other medications? There are various new medications that can be used. Metformin is an insulin sensitizer. Remember, the problem with PCO is that it results in high insulin levels because insulin is resistant, it's not working well. So metformin tries to make this insulin work well, and hence it reduces the high insulin levels and hence reverse some of the metabolic problems associated with PCO. Inositol is another such chemical. It is a newer medication. It is marketed as a health supplement, but given in correct doses, it does act as an insulin sensitizer and is quite well tolerated, better tolerated than metformin. So these will help metabolism and reduce the metabolic problems associated with PCO. Vitamin D, again, is a new therapeutic option. We know that vitamin D deficiency can aggravate PCO symptoms. And so testing for vitamin D and taking vitamin D supplements does help alleviate PCO symptoms and reduce, again, the metabolic risk. Now, all these need to be used in the long term and need to be associated with lifestyle and diet changes. There is no shortcut in the treatment of PCO. So now I will quickly go through some cases, some of my patients, just to show you the breadth of presentation of PCO. This 16-year-old girl presented with clinical depression. On history, we figured that she was a small for gestational age baby. She was only 2.3 kg at birth. A history of diabetes and hypertension in dad, which started at 35 years, so quite an early onset of metabolic problems. She had an early onset of periods, so periods started at 10 years, and since then, only 2 to 3 periods a year. She's always been plump in the childhood. Again, remember, she had a thrifty metabolism, intrauterine, and then small baby when she was born. But then she was because of the nutritional surplus, she resulted in putting on weight too much, and that resulted in morbid obesity from puberty onwards. And in puberty, again, she started developing this male pattern hair growths on the chin, upper lip, around the nipples, below the umbilicus. A lot of hair developed together with acne. So when she presented to me, we had to do some investigations, sugar, hormonal profiles, sugar test, thyroid, and vitamin D. And then we had to put her onto the interventions like weight loss together with diet, which is essentially a low carbohydrate diet, also an anti-inflammatory diet. When my patients come to me, I spend about a long time, actually, longer about the lifestyle modifications than about medications. So diet and exercise is an important part. Metabolic issues will need metformin or inositol to help get it corrected. Hirsutism, you can get laser done or use various forms of contraceptive pills or hormonal medications to lower the male hormone level in the body. Again, hormonal medications need to be given to regulate her periods together with vitamin D supplementation. And we hope that with all these interventions and with some therapy, as her weight becomes better, body image issues go away, this depression will also go away. Another woman, and this is a very common presentation, very few girls present so early on. Mostly we see women in their 20s and 30s. So 34-year-old women presented with infertility. She's a slim girl. She had periods starting at 12, which is average, but then periods every 2 to 3 monthly only. She's been married for 7 years and hasn't been able to conceive despite trying for the last 5 years, and that is resulting in marital issues. So we have to do hormonal profile. When periods are irregular, hormones need to be figured, and we need to figure out where exactly is the problem. We need to do sugar tests, despite the fact that she's slim. We need to do thyroid and vitamin D investigations. So interventions would include metabolic issues. If PCOS is confirmed, then we have to put her on metformin and inositol. For her fertility concerns, we have to do ovulation induction, means we need to change her hormones such that this egg that is not able to grow will start developing. And of course, vitamin D supplementation will help, and marital issues need therapy to be done. Case 3 is a 36-year-old with irregular menses every 4 to 6 weekly since she started having them. She is fairly normal BMI, has some hirsutism and acne, but presents with secondary infertility and multiple miscarriages. Family history is significant for diabetes and hypertension, and now she's pregnant again with treatment, but is very, very anxious. Again, we would have done a hormonal profile for her, no point doing it now, but based on all these tests, we would have figured out that she has PCO, and if so, despite being pregnant, we have to counsel her about proper diet. So carb control is very important. We will have to start her on metformin because that will, even during pregnancy, help sensitize the insulin. It is an anti-inflammatory, and it will reduce the chance of her having this late miscarriages that she's been having. We'll have to support the pregnancy with some hormones, and vitamin D will aid in rectifying all the metabolic problems for her. Now, this 45-year-old has periods every 6 to 8 weekly, sometimes prolonged menses, sometimes bleeds up to a month. She's always been obese. History of infertility, needed fertility treatment, but finally had one vaginal delivery. On ultrasound scan, we did check, we found an endometrial polyp. And when this polyp was removed through hysteroscopy, it showed pre-cancer. So again, we have to do hormonal profile, sugar tests, and vitamin D blood tests. We need to intervene. Weight loss and diet will be the cornerstone of the treatment. Metabolic issues need to be sorted, but with metformin and inositol, and prevention of endometrial cancer. For prevention of endometrial cancer, Mirena IUD would be the best option. Of course, vitamin D supplementation will be useful. So all these things, if we catch PCO early on, then we avoid this patient, which was missed all through. She did not seek any treatment. 54-year-old with no kids, had irregular, infrequent periods, and was very happy thinking that, oh, I don't have to have periods. I have only 2-3 periods. Had a history of infertility, of obesity, diabetes, and hypertension, but no one ever could string all these symptoms together. She was treated separately for each of these, but nobody could link it back to the PCO. She had menopause at 52, then presented with postmenopausal bleeding. On scan, we found a very thickened endometrial lining, and DNC done showed endometrial cancer. So as you see in the previous 4 cases, there were opportunities at every level for us to intervene and try and reduce the chance of problems and endometrial cancer in this woman. But this woman was unfortunate because she did not get the correct medical attention, and hence she has full-blown metabolic syndrome, obesity, diabetes, hypertension, as well as endometrial cancer. So we strive to prevent these problems, or prevent women from having this, and we hope that with interventions, with proper medical care, and very importantly, lifestyle modifications, we can make endometrial cancer a thing of the past. Okay. So let's take a deep breath and blow out, and then move on to endometriosis. So endometriosis is the new kid on the block. When I was training in the 1990s for my gynecology advanced training, we had maybe a chapter for 2 pages in the book for endometriosis. Of course, now about 25% of any gynecological book is dedicated to endometriosis. So what is this? Endometriosis is a condition where the endometrial tissue is the tissue which is found inside the uterine lining. So if this endo means inside, metrium is the uterus. So endometrial, inside uterus tissue, is found outside the inner cavity of the uterus. So it's not just here, it's found at other places. Then that is called endometriosis. So this is what a normal pelvis looks like, and I apologize for some graphic pictures, but it helps understand those of you who find it difficult to see. You can maybe look away or just listen to the talk instead of seeing. So this is what a normal pelvis looks like when we are looking at it laparoscopically. This is the uterus over here. Uterus is a small organ. It is the size of a chicken's egg. These are the two ovaries, which are the size of, say, a walnut or a prune, and they are nice, shiny, white organs. These are the two fallopian tubes, which are slim, thin organs that help transport the eggs. And the intestines are right behind the uterus, but like good next door neighbors, they don't interfere. All these organs don't interfere with each other. This is what endometriosis looks like. Endometriosis results in distorted pelvic anatomy. The uterus is oftentimes a little bit swollen. The fallopian tube may be swollen. The ovary is swollen because of cysts. And the intestines, as you see here, is stuffed. You can see a whole lot of scarring happening over here. So why does endometriosis happen? The most common theory of endometriosis is retrograde menstruation or backflow of periods. So instead of having periods in which this endometrium or the inner lining of the uterus is shed out, so in normal cases, menstruation just flows outside of the body. But in some women, this menstrual blood flows through the fallopian tubes to the inside of the pelvis as well. This blood carries the endometrial cells, the cells from the inner lining of the uterus, with it, and these cells then can get implanted on the internal organs, resulting in the formation of endometriosis. Now, why is endometriosis becoming common? As I told you, in the last 25 years, we are as if seeing an epidemic of endometriosis. Why is that? Because in the last 3 decades, women are having fewer and fewer babies. Our mothers and grandmothers had many more babies than we did. And as women are having fewer babies, they are having more periods. More periods means more chances of this endometrial lining to implant on our pelvic organs. And because of that, we are seeing much, much more of endometriosis. So why is this endometrial tissue that's outside the uterus so bad? Because this endometrial tissue, just like the tissue inside the uterus, is hormone dependent. So just like the womb lining responds to the hormonal changes and results in a period, this tissue, which is outside the uterine lining, also responds and bleeds. So essentially, you are having internal periods. Now, periods that are happening in the uterus can flow out, but periods that is not flowing inside, that is not found inside the uterus, there is no outlet for menstruation that's happening outside the uterus in the ovaries or other parts of the pelvic organs. There's no outlet for this, and it keeps getting accumulated, resulting in the form of endometriosis. So this is what it looks like in a woman who's having internal periods. This is the uterus here. From the fallopian tube, you can see the brown blood over here, but there is no endometriosis that's developed just yet. This is the ovary, nice shiny white. The tubes look nice. The intestine is behind here, and nothing is stuck to each other. Over time, if this keeps on happening, it can result in this menstrual tissue getting stuck onto the ovary, and then this ovarian menstruation, which has no outlet, will result in the formation of this big cyst, as you see in the bottom picture. Okay, so Now, what happens when endometriosis starts to develop? The body tries to do away with it. So there's essentially chemical warfare that's going on inside the body. And that chemical warfare is what gives rise to the symptoms of endometriosis. So there will be pain, inflammation. The body tries to kill this cell, which is present at the incorrect place, and that will result in scarring and long-term damage. Now, this issue keeps happening month after month. So every month, more and more tissue gets deposited inside. It can get worse with time, and which is why just clearing it once doesn't fix it. It can wreck after treatment, because this backflow of periods will keep on happening until she becomes menopausal. Endometriosis is very common. 1 in 10 women are affected by endometriosis, and it affects millions of women in the world, regardless of their ethnic and social backgrounds. Why is it important? Why are we talking about endometriosis today? Because women with endometriosis struggle to get an accurate diagnosis. On an average, it has been shown it takes 6 to 7 years before a woman with endometriosis gets the correct diagnosis. 3 out of 4 will experience a misdiagnosis, or their symptoms are minimalized. Doctors say, oh, period pain is a normal part of periods. If you are a woman, you need to learn to bear pain. Otherwise, how will you give birth, etc., etc., etc. The list goes on. So what are the symptoms of endometriosis? Pain, pain, and more pain. Could be painful periods. It may cyclical period pain may start before the periods. It may last through the periods. It would be continuous pain even without the periods. This is called as baseline chronic pain. Pain all the time and made worse during the periods. And periods may sometimes be irregular, maybe frequent, or maybe heavy. Now, when patients come, they say, how do I differentiate if my period pain is not the usual type of period pain? So if you're having difficulty moving about and want to just lie in bed during periods, you're unable to go to school or work by popping, say, a Panadol or 2. So if it's affecting your daily life, if you need to take a medical leave monthly during your periods, that should make you see a doctor, because that really means that there's something not quite right going on inside. Other women may experience painful sex, especially the sex is not on the superficial, not at the entry point, but it is when the penis is deep inside, so on deep penetration. And this can put a strain on relationship as well as self-esteem, as well as contribute to fertility issues. Some other women will have pain while passing urine or motion, and others in whom endometriosis has deeply invaded into their rectum can result in rectal bleeding as well. Some women have no symptoms, but I don't know whether they are lucky or not, because that means the endometriosis just keeps hiding and developing and becoming more and more severe. So how do we diagnose it? When a woman comes with such symptoms, which I've told you before, we take a very thorough history of the pain, how long it has been, how much is it impacting her quality of life. We do an examination for her, which is a vaginal examination, an internal check, which may be painful. A rectal examination may be needed sometimes to evaluate the rectal involvement in endometriosis. We will always need to do a pelvic ultrasound scan, and in most cases, it will have to be done vaginally. If a woman is a virgin and she does not want to have a vaginal ultrasound scan, then we can do a transrectal ultrasound scan. This is important because just abdominal scans will not be able to help us see endometriosis unless it makes the ovary develop big cysts, which indicates a more severe disease. In women who need surgery, we will do MRI scans. We are doing less and less of that now because we are becoming good at the pelvic examination as well as pelvic ultrasound scan. When I was training, we were told diagnostic laparoscopy is or keyhole surgery, and biopsy is the gold standard, but it is no longer first line. We don't need to do a surgery to diagnose endometriosis. We can, based on history examination, ultrasound scan in most cases, all of which can be done in the gynecologist's office, we can make a presumptive diagnosis of endometriosis and start the treatment. So this is what an endometriotic ovary looks like on pelvic ultrasound scan. This is what we call as a chocolate cyst because it has old blood, which is very thick. So it looks not red, but brown in color. And oftentimes ovaries are stuck to each other, a term which is called as kissing ovaries. So here you see cysts in both the right as well as left ovary. You can see this characteristic grayish pattern that is there in the ovaries. So endometriosis can result in fertility problems. How does a woman get pregnant? This egg develops because of hormonal changes in the ovary. From the brain, the egg will start developing. It will get released. It is picked up in the fallopian tube. At this point, if she has sex, then the sperm will swim up, fertilize the egg over here, and then the tube will push it back inside the uterus. Now, what causes infertility problems in endometriosis? It could be that because of the chemical warfare that's going on in her pelvis, there is the presence of a lot of peritoneal chemicals which can affect the egg quality. It may be that her fallopian tubes are swollen, like you see over here. This is called hydrosalpinx, and these can be blocked because of the endometriosis. Sometimes the tube-ovarian relationship is distorted because when the egg is released, the tube has to be just there to pick it up. But if the tube is swollen and it is stuck somewhere else, then the tube-ovarian relationship is distorted and the egg cannot be picked up by the fallopian tube. Endometriosis kind of chews up on this ovary. It kills the eggs that are there inside the ovary, so results in reduced ovarian reserve. And finally, adenomyosis, which is endometriosis of the womb, results in womb swelling, and the environment inside the womb is not conducive for implantation. So adenomyosis results in an implantation failure as well. So adenomyosis, as I just said, is the endometriosis of the uterus. The endometriosis is in the muscle wall of the uterus. Remember, the lining should only be in the inner cavity, not in the wall of the uterus. The presence of endometrial tissue in the wall of the uterus results in adenomyosis. This is what a normal uterus looks like. Adenomyotic uteruses can be big. The largest adenomyotic uterus that I've seen is the size of a watermelon. So it can really, the size, normal size being a chicken's egg, it can really become big as a watermelon. So we try, in today's day and age, we try not to let a woman progress on to such severe problems. Okay, so this is what the MRI and pelvic ultrasound scan of adenomyosis looks like. Other causes of infertility: painful sex results in infrequent sex, and that also contributes to the infertility. Generally speaking, women with endometriosis have much lesser than normal women the chance of conception every month. Women will have a chance of 15 to 20% chance of conceiving every month if they're trying for a pregnancy, but women with endometriosis have much lower chance. And 30 to 50% of endometriosis will have fertility problems. Endometriosis goes hand in hand with fertility issues. So endometriosis patients will have reduced fertility, and women who have fertility issues are increasingly being found to have various degrees of endometriosis. So what do we do about this horrible disease? Early diagnosis is key. We have to suspect. Even if there are no immediate plans for fertility, we have to explore fertility issues, because if we keep it till much later, maybe we are not able to help this woman have a baby. So if a woman does not have desire for childbearing, then we can use, in a teenage girl, when we're not so sure about the treatment, we can give them painkillers to reduce this chemical warfare that is going on inside the body. But most women who have endometriosis will not respond well to these, and at some point they will need hormonal therapy. What do these hormones do? They suppress ovulation and stop the menses, or give rise to very light periods, and these may may be a variety of medications can be used. It could be either be the contraceptive pill, it could be in the form of progestogens, Visan, and I'll talk a little bit more about this. It could be GnRH agonists, which are medications or injections that put the woman in temporary menopause for a while. These are effective, but do have side effects and are quite expensive. Alternatively, we can use the Mirena, and I'll talk a little bit about this as well, or the Implanon. All these are contraceptives. And we'll talk about fertility treatment in just a while. So Visan is common medication now that is being used for endometriosis. It's a form of progestogen. Progestogen there are two types of female hormones, estrogen and progestogen. Progestogen is the pregnancy hormone. We have noted that pregnancy does suppress endometriosis. So that's why various types of progestogens have been developed to try and suppress endometriosis, and Visan has been found to be the most effective. It is first line today for most patients. It's given in the form of oral tablets that are taken daily without any gap. 80 to 90% of patients will report pain relief. It does have side effects. There's no medicine that does not have side effects. It will cause irregular spotting. Most of my patients will experience this irregular spotting for about a month. After that, there will be no periods. And oftentimes women ask me, is it okay if I don't have periods? Yes, it is fine not to have periods if you're not wanting to get pregnant. Breast tenderness, mood changes, and hair falls are usually temporary and uncommon side effects. Most women who are on Visan love it, and they do not want to stop. We have about 7 to 8 years of experience of giving Visan non-stop, and so far there have been no long-term issues. Studies are continuing to help us know more about long-term use. Mirena is an intrauterine contraceptive device which can be inserted in the clinic. It lasts for about 5 years, shrinks the uterine lining. Again, if they do not have a lot of period, then no backflow of periods, and that helps women who have endometriosis. It takes about 3 to 6 months to settle. That's the issue. After that, women may have irregular, very light, or no periods at all. There can be some women who have temporary cysts. Now, some women don't like things to be inserted into the uterus, and Implanon, which is another hormonal device which can be placed in the arm, is one such other option for these women. Women who want to get pregnant, some of them will require surgery, but surgery for infertility issues in endometriosis is not essential. It's not dependent just on cyst size. Infertility alone is not an indication of surgery. Surgery for endometriotic cysts has been shown to permanently reduce ovarian reserve, and this damage increases as more and more repeated surgeries are done. So surgery is indicated for uncontrolled pain. If medication are not able to help, then we have to do surgery, and we aim for only one surgery to be done, hopefully in her 40s, to finally deal with the disease, and it should be done by a surgeon who is well versed in management of endometriosis. So if there is infertility, usually some form of fertility treatment is recommended, either supovulation, IUI, or IVF. I won't go into much detail, but the two different methods these are two different assisted reproductive methods, either IUI, but a lot of women will need the more complex treatment, IVF, in which we have to extract eggs, fertilize them in the laboratory, and then transfer them back inside the womb. So different fertility options, IUI, supovulation, IUI, and IVF, with different time commitments and different costs are there. The important thing is that fertility treatments for endometriosis women are less successful than in women who do not have endometriosis. Now, there are certain important ancillaries to treatment: exercise, dietary changes, especially avoiding dairy, wheat products, and soya because they are pro-inflammatory, eating more anti-inflammatory fruits like grapes, strawberries, kiwis, nuts, eating more vegetables, especially cruciferous vegetables, onions, garlic, red and green peppers, and green tea, which is a plant-based compound, which has plant-based compounds which are used to suppress estrogen-related activation. So they reduce the volume of endometriotic implants. So these are good. There are certain wheat replacements that are useful in women who have endometriosis, and certain supplements like vitamin D, coenzyme Q10, folic acid, omega-3, zinc, and vitamin E. Of course, TCM, or traditional Chinese medicine, acupuncture, and reflexology all seem to assist and aid treatment of endometriosis. So if if a patient wants to, she can use these together with medical treatment as well. So just to demonstrate again the breadth of how endometriosis presents, patient 1 presented with 3-centimeter endometriotic cyst, and she was advised to go for surgery. She came to see me for a second opinion. We started on Visan for 9 months. The cyst shrunk, and 3 months after stopping Visan, she got pregnant. She's delivered, stopped breastfeeding, and then cyst record. We started on Visan again for 6 months, cyst shrunk, and she has conceived and delivered again. Another patient, she had 2 laparoscopic surgeries done in 2 different hospitals, and this was resulted in, was not done properly. So within 6 months, the cyst came back with a vengeance, about 7 centimeters. So we had to do complete surgery for her because she was in tremendous amount of pain. After that, she had to be given GnRH agonist for 6 months. She tried 2 times. She did not get pregnant, but eventually with medication, she conceived after 2 years, and she has delivered. Another patient, again, cyst was resected in Malaysia, and she had big adenomyotic uterus. She presented with cyst recurrence, and we again had to do a surgery for her because she was in tremendous amount of pain. But that was followed by GnRH agonist to shrink the adenomyosis. We did IVF, she conceived, and from that 1 cycle, we got enough eggs that we were able to help her get pregnant 2 subsequent times as well. Another patient, 35-year-old, she had 2 previous surgeries for endometriosis. This was followed by short-term medical management. She had swollen tubes, which was not addressed. So she presented with infertility to me. We did GnRH agonist to shrink all the adenomyosis. This was all during the COVID time. We did IVF. And then we had to go in again to do a laparoscopic surgery to fix this swollen tube. And then she has gotten pregnant with IVF, and she has delivered a healthy baby. Now, this is what we don't want to happen. 29-year-old with 2 previous surgeries, and it was so severe, and that had resulted in egg reserve. Her endometriosis was so severe that it had involved the intestines as well as the urine bladder. We had to do a surgery. It was a 10-hour surgery combined with my colorectal and urologist colleagues. And after that, she's pain-free, but despite IVF, we have not, I don't think we will be able to help her with her fertility concerns. So to go back and to give a summary, female age, duration of infertility, and stage of endometriosis should be taken into account when formulating a management plan. Early diagnosis is key to endometriosis. Pain or improving access to ovary is the only indication for surgery. We do not need to do surgery for everyone. If laparoscopy is done, surgeon should attempt to remove all visible lesions, no half-hearted surgery, no repeated surgery. Post-op medical suppression is essential, and there has to be proactive fertility treatment with an early recourse to IVF, especially in the older patients. So that's it. Do reach out if you or you know of anyone who has any of these problems. I'm there to help and try and cope, try and make you understand what you are dealing with, and try and help you cope with this condition, because both these conditions are long-term problems. It's not a quick fix that you come, I do a surgery, or I give you medication and it's gone. So those are my coordinates. Millions suffer in silence. Please do not let it be you. You can find out more about the symptoms by filling out this comprehensive questionnaire. That's the QR code, and you can use your phones to go on to it. Thank you very, very much. And I'm happy to take questions.
Yes, Dr. Anna, we have a few questions for you. So if you stop sharing and take a sip of some water.
Thank you. Yes.
Water or coffee.
Yeah.
And I'll start to read out some interesting questions that we have on on the chat. So first one is one of my questions, actually. So are there other treatments for teens suffering from these diseases, apart from giving the pill, for example? Are there a bit more of a holistic, so that we don't, screw up the hormones, as we say,
Sure.
in early life?
Yes, so you can use, so remember for PCO, it will depend on the cause. So if it's PCO, we can start with inositols. We know they are just like health supplements. It's a powder, you mix it in water and gulp it down, and that lowers the insulin level together with lifestyle changes. You cannot be having inositol and then eating like bowlfuls of pasta for breakfast, lunch, and dinner. That will not work. But together with a low carb diet, some form of insulin sensitizer will assist in keeping the weight down, normalizing the insulin level, normalizing the hormones, and resulting in fairly regular periods. For conditions like endometriosis, it's a little more difficult. Again, a lot of focus on diet and supplements, anti-inflammatories, and but if a lot of symptoms, most of these girls will require some form of hormonal treatment to suppress the disease, because endometriosis will continue to develop throughout her reproductive lifespan.
Okay. Okay, that's a good explanation. Actually, a friend of mine is her daughter is suffering, and she is, when she gets her period, she vomits, especially on the first days of the period. And she's on something called Ponstan. What is that? That's a contraceptive pill?
No,
is it?
Ponstan is an anti-inflammatory, so it's like of the same group as aspirin. It's a painkiller. It's a painkiller and anti-inflammatory.
Okay, but that doesn't seem to help. Any advice on what the next steps should she be taking for her daughter if it doesn't really work?
So see a specialist and check and see whether is there, she has to be on regular follow-up. So over time, if there is endometriosis, then either digital exam or ultrasound scan will reveal, the endometriosis will reveal itself, and we can find it out. If we find these problems, then we have to start treatment, which will most likely be in the form of hormonal treatment. But lifestyle things will be good. You cannot disregard those. So like coenzyme, like vitamin D, vitamin E, omega-3. So those are things that can help reduce the inflammation in such women, and they should be used.
Okay, another question is, if I have, excuse me, if I have PCOS, will I have to take birth control for the rest of my life?
Definitely not. You don't have to. It depends on what is the presentation. This is old time. Once PCO, maybe 10, 15 years ago, all women have to be on birth control till at least their menopause. But now there are so many other things that we can do. And primarily is weight loss, low carbohydrate diet, because your body is struggling with insulin. You just keep pumping more and more carbs, the hormonal imbalance, which will keep getting worse and worse. So there could be so many other things. Could be metformin that is used, inositol that is used, or a Mirena can be inserted. If you've completed your family, you don't need to subject the entire body to hormones. Use hormones where they are needed. Uterine cancer is a problem. We put the Mirena, it will release the progesterone hormone just in the uterus, and you don't need any more than that.
And can you control the hormones that are released by the Mirena, or is that like just already fixed?
It's fixed. It's fixed. It's a very minuscule amount. And the good thing with Mirena is it doesn't go to the entire body. Mirena will just release it inside the uterus.
Right. Okay. That's a good insight. And how much weight are we talking about when you say, oh, I suppose this is quite a broad question.
10% of body weight. So if you're 70, 80 kgs, you are looking at, unless you lose 10 to 15% of body weight, your metabolic profile is not going to change. So you
Okay.
have to, if you're 100 kgs, then lose 10 to 15 kgs. If you're 70, 80 kgs, then lose 7 to 10 kgs. So it depends on how overweight you are. About 10 to 15% of that weight needs to be lost for
Okay.
it to have metabolic effects.
Okay. And obviously, when you lose those weight, results obviously are going to sort of come and be present, hopefully.
Yes. Yes.
Okay. Another question from Christine. Hi, Dr. Anu. I am a PCOS patient currently, 6 weeks pregnant via IVF. Congratulations.
Yeah.
She says that I am on, I hope I pronounced this right.
Yeah, she's on a whole lot of
inserts?
pregnancy support medications, Susan.
Yes. So anyway, she has put it on the chat, and she's asking, how is there anything else she should take to improve her pregnancy?
So, I mean, it depends. Not everyone will need all the medications that I've mentioned, but certainly if there are, say, risks of miscarriage or based on her body profile and HSCRP, which is an inflammatory marker, I feel that there's a lot of inflammation that's going on in the body, which will increase her miscarriage risk. Then certainly I will talk about giving metformin. Women who are not fulfilling those criteria, then things like, say, vitamin D supplementation would be useful as well. But, and again, a low carbohydrate. Being pregnant, I'm sure she suffered so much, she would be just wanting to enjoy and eat whatever she wants, but no ice creams, no cakes. That will not be a good idea for a woman who's pregnant with PCO.
Okay, that's good advice. Is PCO the same as ovarian cysts?
So PCO, well, the short answer is no. PCO means there are a lot of eggs inside the ovary, which does not, because these eggs are not getting released from the ovary. It's a greedy ovary, it doesn't release the egg. It has just so many eggs. That is a PCO ovary. Ovarian cysts are usually solitary, 1 or 2 big fluid-filled structures inside the ovary, which may be 3, 4, 5, 10 centimeters in size. So those are different from PCO.
Okay. One question from Nurul. Why does PCOS increase miscarriage risk?
Because of hormonal imbalance. There's high male hormone, which results in high inflammation in the body. This is different from a female-based hormonal profile, which is conducive for, I mean, only females have babies, right? So if there's too much of male hormone, the reproductive organs don't work very well. And there's a lot of inflammation in the body. So this body is not of an optimal female phenotype, which supports a pregnancy.
Okay. What is the difference between fibroids and endometriosis? So
fibroids are tumors of the uterus, and endometriosis is the presence of endometrial tissue outside of the uterus. They are totally different things, but they can coexist in some women.
Oh, okay. And are fibroids super dangerous as well, or not so?
I mean, 1 in 5 women will have fibroids. Oftentimes, it will not give rise to any problems, but sometimes it will cause heavy periods or painful periods or, periods in between, fertility issues, bleeding in between periods, depending on their size and location. Yeah.
Okay. Another question. If I have polycystic ovaries identified through ultrasound and irregular periods, but with no hirsutism, would the next advisable step be to do blood work?
Yes. We need to know the hormones. We need to know why are your periods irregular, because there could be so many reasons why that is happening.
Okay. Let me just see. I've asked this. I just asked this one. How many kilos are we talking about when we say obese? You've answered that one. Is it harder for PCOS women to conceive?
Yes, because you are not ovulating. So if no egg is getting released, it will be difficult to get pregnant.
Okay. Another question. Can the progestins and GnRH agonist prescribed by a GP doctor?
No.
Or have to prescribe you?
Yeah, it is prescribed by gynecologists.
Okay, this is an anonymous question that just came in. I have a 21-year-old niece, and she has been undergoing treatment for PCOS for the past 4 years. So she's 21, she's been doing treatment for 4 years. She initially was given metformin and vitamin D. Now with a change of doctor, she has been told that she doesn't have PCOS. But then she's but the Just Obese, the new doctor has given her a lifestyle change and suggested that she go on an obesity drug. Can PCOS sometimes be misdiagnosed?
Yes, and then it can change as well. I mean, obviously, she has been doing some interventions. The first doctor has put her on vitamin D, which we know now will not take away PCO, but it does aggravate. So maybe what was a more severe, more obvious disease is becoming a much milder, much less obvious disease. So, yeah, I mean, it can be misdiagnosed. I suppose blood work can help. It's a package. It's not just one symptom which will make or break the diagnosis.
Yeah, and I suppose all women are we're all different, and we come in different, and when they see you, they all come in with different problems. So when people come and see you, what do we have ready? Do we have to show you sort of like months worth of
it's good to have it's good to have a menstrual like a diary, because that's very easy to see how the periods are, and then we can prescribe the appropriate tests.
Okay. And in your experience, how long does it take for women to find the right type of medicine, contraceptive, that they're happy with? Like, bearing in mind that hormones work differently in different women. One woman might find one hormone dose is great, but another one would probably find it like crazy, make them crazy and depressed.
Correct. Yeah. So usually, see, the effects will take a while. So we can change medications every, say, 2 months or so. It's no point changing very, very quickly, because sometimes the side effects may be temporary. And so in most cases, within 4 to 6 months, we are able to either figure out what works or say that oral medicines are not for. Then we have to look at non-hormonal things.
Okay, but it's not gonna, if I take it for like the first week and it's making me crazy, I would obviously have to tell you, but you say give it a chance.
Yeah.
Okay. Another question about vitamins. Is there a one-stop shop vitamin that we can take, like all in one pill for all the vitamins, things that you've listed?
No. You have to, it has to be for specifically for these things. It is not a one dose that can be, because most of those one dose pills will be only for maintenance. They will have a vitamin D, but the amount is minuscule. So those are only if you are in good health and you want to remain so, then that's those 1 a day kind of Centrum or whatever. Those are just for maintenance. If there is a problem, you need to take much higher doses of each of those medications.
Okay. But for us, who don't really suffer, but have it in the back of our mind going, actually, sometimes I do have pain. A generic women's vitamins is enough.
Yeah. I mean, if there are no obvious issues, then generic for the well woman, usual vitamin is good.
Okay. And what do you advise women who cannot seem to lose weight? Like, I'm trying to lose like the 5 kilos that I've acquired since giving birth. And this is almost now 9 years ago. Can't seem to shake it. What's up? Like, I have to say, I do love carbs. So that's probably one of my downfall. But for those who need to lose weight, but finding it really hard, what would you say?
I would say see a dietitian. You
Mm.
need to understand, because oftentimes, even as a doctor, when I was struggling with weight issues after my second one was born, there was a lot of things I was doing wrong, which was blatantly wrong. Now I know it was wrong, but at that time I thought, what's wrong with drinking a smoothie? It's healthy, but it's not. It's not so for my body type anyway.
Yeah, that's a good idea to see a nutritionist, because
Yeah.
what I think is good is probably really bad, like as you said.
Yeah.
Okay. Maybe eating ice cream when I was like really pregnant was not such a good idea.
That's a great idea. Yeah, that's why I tell my patients, you don't think that you are getting the leeway to just do whatever in terms of your diet when you're pregnant, because this is not just now. It affects your baby. You are teaching your baby how to eat while she or he is in the womb, and B, you have to lose it all back later to be to have a healthy weight later on.
Yeah, I totally agree. Like I ballooned to about 100 kilos. And I remember my Dr. Paul saying, he's like, you gotta stop eating cakes and ice cream. I was like, oh my God. I just had so much water retention as well. So maybe that was part of it, but that's another talk. Okay, so another question is, I was diagnosed with sorry, excuse me, endometriosis in my 30s, and today I'm in my 50s and currently in menopause. Do I need to do any further tests?
No, but you just need to go for a regular annual check to make sure that these cysts remain quiet in menopause. For most women in menopause, their endometriosis is suppressed, it is quiet. But for a minority, less than 1% of women, there will be endometrial, not endometrial, but ovarian cancer, endometrial type ovarian cancer that grows in these ovarian cysts. So you need to be checking on it once a year should be good enough. Or if at any time you have strange symptoms like bloated and not feeling great, loss of appetite, strange things need to be checked.
Okay, so it doesn't actually go away when you hit menopause.
I mean, for majority, it will go away, but for the minority, and who knows who is in that minority.
Yeah, that's true. Okay. Will anti-nausea medicines help to take with Ponstan?
No. I mean, if they have nausea, then yeah, you can take it together with. But what I feel is a lot of women or girls will wait for the pain to reach a crescendo before taking medication. And that's not. You have to, if periods are painful, and I struggle with my own daughter with this as well. If your periods are painful, you know it's going to be painful. Why are you waiting for this pain to peak before you take the medication? When your period starts, just take medication. That will reduce the amount of medication that you will need to use. And it will definitely make it easier for the medicine to work on relieving your pain.
Yes, that's a good tip, because a lot of people are like, oh, actually, I do, a lot of people wait till the pain comes and then suffer and then wait for the painkillers to kick in. But then the pain is so much, it doesn't really kick in, right?
Correct.
Okay. What should adolescents with PCOS focus on in terms of their diet? No carbs, you mentioned. Well,
yes.
Less carbs.
Less carbs. They need carbs to grow, so they need to eat less carbs. They need to eat more fruit and vegetables, which is a challenge with today's teenagers. They like to eat a lot of outside food, this Deliveroo and Grab food or whatever, just makes it so easy for them to eat outside food, which is not very good.
Yeah, we have to be mindful of what we actually buy and serve our kids as well. I never actually really thought of that until now. I mean, I am pretty healthy, but sometimes the treats that you get for them, right? Another question, can you have PCOS if your blood test is okay? LH, FHH, okay, but still regularly have cysts.
Yes. So remember, it could be clinical, which means if you have hair growth where it shouldn't be, or your blood work shows high testosterone, and if you have the PCO appearance of your ovary, that makes you having PCO based on the diagnostic criteria.
Okay. This is an interesting one. This is the opposite. Conversely, if a skinny, underweight girl who has such female hormonal issues, so instead of losing weight, what else can she do?
So extremes of weight is a problem. Some skinny girls will have very frequent, very heavy periods. And for them, we actually tell them that they need to eat healthy to gain some weight, to come back in the normal weight range. And they may, even though they are skinny, and I see that specifically in the Chinese ethnicity. And it's so interesting that here in Singapore, we are able to see a variety of ethnic people, so we can very quickly compare. Chinese girls will be skinny, but their metabolism is not the great. They will have high sugar levels. They will have inflammation in the body, and we have to somehow reduce those levels. So vitamin D supplementation, taking omega-3 to reduce the inflammation in the body, maybe giving them inositols or metformin to, again, lower the insulin levels. Those are very, very important.
Okay, those are good things to remember. What are the long-term side effects of contraceptive pills?
I've answered that actually directly. They are minimal. The new contraceptive pills have very, very minimal side effects, and they can be used from menarche to menopause. So the entire reproductive lifespan, they can be used.
Okay, that's good to know, because when I was taking mine, I had to try so many, and some of them made me eat crazy. So that's good to know now. How does blood pressure in a 25-year-old affect her fertility?
Blood pressure.
Maybe she has high blood pressure.
High blood pressure. So if it's hypertension in a 25-year-old, that needs to be investigated properly. It could be because of so many reasons. It could be because of kidney disease or some other endocrine problem. That's certainly, there's a full workup for the young hypertensive. So that needs to be done. And if it all boils down to PCO, then we need to again talk about how we get the hormones balanced by lowering the insulin levels, by a variety of lifestyle as well as medical measures.
Okay. And what is your advice for someone who has had ectopic pregnancy in the past? Should they come and see you for a checkup to make sure that they don't, to avoid these problems in the future? Okay, last one. Do hormonal pills have side effects such as hyperpigmentation in young adults?
Very rare. Now, these days, the side effects are very, very rare.
Okay, another one. Can you recommend a nutritionist? Do you work side by side with a good one?
Well, I used to work with Dr. Meenu Agarwal, but she has relocated to Dubai, but she is still available for online consults. And those work these days after COVID. No, everybody has realized that if you don't need to be examined, it's just a teleconsult would be good. So she is in Dubai, but she does do teleconsults. I found her approach quite useful. For myself also, I have understood a lot of problems that in my food, which even though I'm a doctor, I thought they were good, and they were clearly not.
Can you give example? Now I'm super curious.
Yeah, like for example, I used to have a smoothie every single day. And I used to keep thinking, why am I not losing weight? I just had 2-3 kgs to lose. Why am I not losing weight? But
it was the smoothie.
Yes. So then
really?
I've stopped drinking smoothies, and that has helped. I've stopped having wheat, and that has helped because I did test later on, figured out that I'm gluten allergic. So we've stopped that. That has made my bowel work so much better. I take a lot of probiotics, kombucha, yogurt, and that helps. So I feel a lot more healthier now.
And do you eat full fat yogurt or
yes,
light yogurt? Because there's like a debate about, are you having full fat?
Fat is not bad. Fat is not bad. If taken in moderation, fat is not a bad thing. I eat a lot of avocados. I do my own sourdough breads now. So that helps. So a lot of probiotics to fix your gut.
Yes, probiotics is another talk that we have to do, because a lot of people don't understand this gut thing, and everything starts in the gut, as people say. Okay, another question. Can we buy inositol over the counter? And what would be the good dose to start with?
Well, I don't think we are using this as a personal consult. Yes, inositol may be available, but medical grade needs to be taken from a doctor. And it has to be inositol, and there are different types of inositol, and a good mixture of the two types of inositols is useful. So I think better see a doctor before you start.
What is inositol?
It's a type of sugar which helps insulin work very well. It is deficient in women who have insulin resistance and PCO.
Oh, right. Okay. Another question. If high blood pressure is kidney related, does it affect one's reproductive system? Is that connected or not?
It's not connected, but it could be part of the same disease. So for example, PCO girls will have hypertension and have fertility issues, but not everyone.
Okay. And one lady said that she has had Mirena put in and she has had hypertension. And does the hypertension go away? Is that part of like the
No, it's hyperpigmentation.
Oh, hyperpigmentation, sorry.
Yeah.
Hyperpigmentation.
So hyperpigmentation is not related to Mirena. It could be because of so many other things. So no, Mirena has minimal systemic effects.
Okay.
The
And
last
last
question
one.
is, I think this will be the last. I've got patients waiting.
Yes.
So is there a link between PCO and dysbiosis? Yes, there is. In PCO, women will have their gut flora is not good. And that is because, again, they have high insulin, they're not able to digest, their body has extra sugar floating around, and that will make the wrong type of bacteria grow much more than the good type of bacteria. We have billions of bacteria inside and on our body, and they are a whole new system. Now we are understanding more and more about this microbiome, which is considered to be another whole system of the body. So we need to fix it, and a good diet. I mean, just taking probiotics, people think just pop a pill and everything will go away. No, what you are putting in your mouth several times in a day is also very important. So yes, taking probiotic tablets will help. But Vivomix, for example, is a good general one, but it depends. Like there are specific probiotics for women who have vaginal infections or urinary infections. So there are certain that are specific for urogenital dysbiosis, whereas there are others that are good for things like inflammatory bowel, irritable bowel disease. So there are others that are good for that. So it depends on what your symptoms are, but PCO girls will benefit with a good probiotic diet. We can supplement it with some tablets, but just taking a tablet and not focusing on the diet is not good.
Yeah. Whatever you put in is very important. And also, probably it's a good idea to write a food diary as well, if people want to come and see you, so you can see what they put in their mouth.
Yeah.
Okay, I gotta let you go. You got patients to see.
Thank you so
Thank you
much.
so much. Thank you so much for such an informative presentation, and thank you for answering all of our questions. I will let people know where they can find you if they have more
Sure.
questions, if they want to see you, in my thank you email. And thank you so much, Dr. Anu. Have a fantastic day, and we hope to see you soon.
Thank you.
Take care.
Bye-bye.
Bye.
Thank you, ladies. Bye.
Bye.